Operative delivery. The best outcome of pregnancy is healthy mother and baby. Ideally, this outcome should follow a normal vaginal delivery with intact perineum. 40–50% of delivery, anyway, is associated with episiotomy or needed the employment of some devices such as forceps, sucker, or needed cesarean section. Some of them need an obstetric maneuver in order to facilitate the delivery. The goal of operative delivery is to expedite delivery with minimum of maternal or neonatal morbidity. Risk of traumatic delivery in relation to forceps, particularly rotational procedures, has been long established. Caesarean section, particularly in the second stage of labor, also carries significant morbidity and mortality. There are three types of operative delivery: C-section, episiotomy, vaginal delivery with devices, or vaginal delivery with devices. Instrumental vaginal delivery. It's the delivery of a baby through the mother's vagina by using an instrument for assistance. And approximately 12% of US-UK deliveries are assisted with forceps ventouse. The incidence of instrumental intervention varies widely both within and between countries, and may be performed as infrequently as 1.5% or as often as 26%. In Italy, the percentage is lower, about 8%, because we use more C-section and Crustile maneuver. Here, there is a huge variability between North and South. Indications for instrumental vaginal delivery are: the most common indications are delay in the second stage of labor, the progression of the baby is not optimal, or the mother is getting tired and cannot push anymore. We can have also poor maternal effort. If the mother does not cooperate, assisted vaginal delivery is not feasible because there need to be synergy between mother and doctors. Fetal distress, including cord prolapse in the second stage of labor, or ECG abnormalities. Maternal indications include severe cardiac, respiratory, or hypertensive disease or intracranial pathology where bearing down effort may be detrimental for her health. Causes of prolonged second stage of labor are due to inadequate uterine contractions, poor expulsive efforts by the mother, or minor disruption, or minor disproportion or malposition. The incidence of instrumental vaginal delivery is slightly more, with use of epidural analgesia, and may be due to inadequate uterine activity secondary to abolition of Ferguson's reflex, due to absence of reflex release of oxytocin due to stretching of upper vagina. Prerequisites for an instrumental vaginal delivery are: the condition of the mother and the fetus and the clinical situation should be considered carefully. There is a great debate regarding when doctors should start to use instruments to help the baby out. Some doctors think you should wait up to 9 hours. On the other hand, the more time passes with the baby who cannot get out, the higher is the risk of having trauma. The medical personnel should introduce themselves to the woman and her partner and explain the reason for instrumental vaginal delivery. The findings of the plan of action and the procedure should be explained. Verbal or written consent should be taken. General examination should include condition of the mother, pain relief, and hydration. Fetal condition should be evaluated based on clinical information and auscultation or cardiotocographic findings. Abdominal examination is important to assess size of fetus, the depth of head palpable, and the adequacy of uterine contractions. Oxytocin infusion should be considered. Bladder should be empty. The vaginal examination should confirm cervix to be fully dilated with absent membranes. Color and quantity of amniotic fluid should be noted. Presentation should be vertex. Excess caput, soft tissue swelling, or molding may suggest the possibility of some disproportion. Position and station. It is the leading bony part of the skull in relation to ischial spine should be identified. Technical details. Make sure the membranes are ruptured, the baby should be in a cephalic position, and the baby should be engaged. Instrument Instrumental vaginal delivery can be performed with mother in the dorsal position and the legs flexed and abducted, or in the left lateral position, but it is much easier when the mother is placed in lithotomy with the buttocks just beyond the edge of the bed. It is preferable to deliver by C-section if the head is above ischial spines. When vertex is below the spines, instrumental vaginal delivery is possible, and different types of forceps and vacuum could be used depending on the position and station of the vertex. You must wait for the mother to start pushing because all the maneuvers are done in synergy. Otherwise, they are not helpful but are harmful. Forceps. Classification of forceps. We have outlet forceps, so fetal scalp is visible, indicated when fetal scalp is visible without separating the vulva. Fetal skull has reached the pelvic floor and sagittal suture is in the anteroposterior diameter. Low forceps when the leading point of the skull is 2 cm or more below the ischial spine, but not on the pelvic floor. The sagittal suture is in the anteroposterior diameter. In forceps are when the leading point of the skull is 2 cm or less above spine but head is engaged. High forceps excluded. So the choice of forceps or vacuum instrument should depend on the operator's experience and the station and position of the vertex. The forceps is made of 2 parts locked together. Many forceps have a pair of fenestrated blades with a cephalic and pelvic curve between the heel and toes of the blades. The heel continues as a shank which ends in the handle. The handles of 2 blades sit together so that they could be held by one end and are kept in place by a lock or on a shank. The cephalic curve is constructed to grasp the fetal head, with the toes of the blades over the maxilla or malar eminences, while the length of the blade grasps the side of the head from the malar head area along the side of the head in front of the ear and the parietal bones in front of the occiput. The pelvic curve fits the pelvis and is minimal in those forceps used for rotation as in cases with malposition, for example Kielland's forceps. Prior to application of forceps, the blades should be assembled to check whether they fit together as a pair. The handle, which lies on the left hand, is the left blade and is inserted first, negotiating the pelvic and cephalic curve with a curved movement of the blade between the fetal head and the operator's hand kept along the left vaginal wall. Right blade is held by the right hand and is applied between the left hand that protects the vagina and the head by negotiating the cephalic and pelvic curve. If the blades were applied correctly, the handle should lie horizontally and lock easily. The parietal bimalar application offers uniform grip on the 2 sides. Sagittal suture bisects the shank, which is over the flexion point, about 3 cm anterior to the occiput. The 3 essential points of applying forceps are sagittal suture in the midline, that is no asynclitism. Occiput 3 to 4 cm above the shank, that is traction will be along the flexion point, not more than 1 finger space between the head and the heel of the blade. Traction is in the direction of the pelvic curve and is synchronized with contractions and maternal bearing down efforts. An epiphysiotomy is usually needed when the head is crowning at the vulva. The direction of traction is upwards, and the head is borne by extension. Maternal complications are greater incidence of maternal vaginal and perineal lacerations, including third and fourth degree tears compared with vacuum deliveries, perineal pain during delivery, hematomas, postpartum hemorrhage, urinary retention, urinary and fecal incontinence. The fetal complications are paralysis of the seventh nerve is rare and resolves within days or weeks. Transient facial and scalp abrasions are not uncommon but clears in a few days. Cephalomatomas and fracture of skull are rare. Usually they heal by themselves in about 1 month. Nevertheless, the breast fracture may need elevation by surgery. Ventouse. Ventouse or vacuum delivery is an alternative to forceps delivery for similar indications in the second stage of labor. There are three types of ventouse: you have silica, silk cap, metallic cap, or omnicap. The ventouse creates a negative pressure that allows you to make traction of the fetal head. The conditions that need to be satisfied for an instrumental delivery need to be checked prior to application. The caps come in different sizes and are usually 4, 5 or 6 centimeters in diameter. The cap is applied over the flexion point, which is 3-4 centimeters in front of the occiput on the midline indicated by sagittal suture. It is halfway between the two parietal eminences and thence promotes flexion to permit the minimal diameters for the vertex to descend through the pelvis. It's important to identify the position of the head. Once the cap is placed firmly on the fetal scalp, vacuum is created by a hand-held pump. Ventouse delivery with respect to forceps delivery. It has increased over the last decade due to evidence suggesting less perineal trauma, including third-degree tears. It's safe as delivery by forceps. The soft tissue sucked into the cap remains as an elevated circular bump called the chignon. Soft tissue swelling settles in the next 2-3 days. It's unlikely to cause vaginal tears or pelvic floor damage. Neonatal injuries are scalp abrasions, retinal hemorrhages, hematoma confined to one of the skull bones. Contraindications: not used in severe premature, less than 34 weeks, babies because of the risk of subgalean hemorrhage, fetus with possible hemorrhagic tendencies because of the risk of subgaleal hemorrhages, morbidity or mortality, or face presentations because if you perform traction in the wrong direction, you may damage the baby. So it's not used in severe premature babies, not used in fetus with possible hemorrhagic tendencies, and not used in face presentation. Caesarean section. It's the removal of a fetus from the uterus by abdominal and uterine incisions. It's increasingly used for safe delivery for fetal or maternal reasons, either electively or as an emergency. A small proportion is contributed by maternal request for non-medical reasons. The improved anesthesia, aseptic, and antiseptic techniques and the invention of antibiotics have made it a safe procedure. It's important that the C-section is performed according to the guidelines. At first you have to make an incision on the skin. Then you encounter, in order, the subcutaneous tissue and the fascia. Then you separate the muscles and enter the peritoneal cavity. You cut the parietal and the visceral peritoneum just above the bladder. The bladder is totally empty because a catheter is to be inserted for the whole duration of the procedure. In this way, you avoid damages to the bladder. Then you make an incision in the uterus. It's better to perform it with scissors or with fingers. It should be large. Then you extract the baby and you suture the uterus into layers. There is no consensus in the literature about how to suture the uterus. Moreover, there is no evidence that the closure of the parietal peritoneum is useful. A large number of techniques and materials for C-section have been proposed to reduce the operating time, the hospital costs, to make the procedure easier for the surgeon. Factors contributing to an increase in rate of C-sections are inaccurate dating of pregnancy, fetal monitoring, macrosomia, maternal request, advancing maternal age, socioeconomic factors, reduced parity, improvement in surgical technique, decreased morbidity and mortality, type of health insurance, whether the hospital is private or public, choose the time and day of delivery, procedures, SI forceps, and difficult mid forceps are abandoned in favor of C-section, and the introduction of epidural anesthesia. The five most common indications for C-section are C-section on request, routine repeat cesareans, dystocia, which is non-progressive labor, abnormal fetal presentation, and fetal distress. Absolute indications for C-section are multifetal pregnancy, placental abruptio, placenta previa, active genital herpes virus. There are 4 categories of C-section according to the timing of this procedure. You can have category 1 or emergency C-section. There is an immediate threat to the mother or the fetus. Ideally, the C-section should be done within the next 30 minutes. Some examples are abruption, cord collapse, scar rupture, scalp blood pH less than 7.2, and prolonged fetal heart rate deceleration to less than 80 beats per minute. Category 2 or urgent C-section. There is maternal or fetal compromise but was not immediately life-threatening. Here the delivery should be completed within 60-75 minutes, and cases with fetal heart rate abnormalities are those of concern. Category 3 or scheduled C-section. The mother needed early delivery but there was no maternal or fetal compromise. There may be concern that the continuation of pregnancy is likely to affect the mother or fetus in hours or days to come. Exempigrazed cause of iatrogenic preterm delivery were need to give a course of steroids for lung maturity. Category 4 or elective C-section. The delivery is timed to suit the mother and staff. These are cases where there is an indication for C-section but there is no urgency, and examples include placenta previa with no active bleeding, malpresentations like bow and breech, history of previous hysterotomy or vertical incision C-section, past history of repair of vesicle, vaginal or rectovaginal fistula or stress incontinence, HIV infection, previous more than 2 C-section. Elective C-section is generally done around 39 weeks. The incidence of tachypnea of the newborn is much less after this gestation. However, the medical or obstetric condition determines the gestation at which the elective C-section is planned, the main principle being to carry out the C-section as late as possible in gestation without compromising the maternal or fetal health. Maternal position during C-section. All obstetric patients undergoing C-section should be positioned with left lateral tilt to avoid orthocaval compression. By tilting the operating table to the left, or place a pillow or folded linen under her right lower back. Anesthesia. Have general anesthetics. An appropriately trained practitioner skilled in the resuscitation of the newborn should be present at C-section, performed under general anesthesia or where there is evidence of fetal compromise. 2. Regional anesthesia. Epidural block, spinal block. Regional anesthesia is regarded as considerably safer than general anesthesia with respect to maternal mortality. Regional anesthesia is generally preferred because it allows the mother to remain awake, experience the birth, and have immediate contact with her infant. The C-section is described based on the type of incision on the uterus. We have a lower uterine segment incision. The lower segment C-section involves horizontal incision on the lower segment after reflecting the visceral peritoneum. This is the commonest C-section procedure. So here the abdomen is opened by a low midline, paramedian, and more commonly a funnel stele, suprapubic horizontal incision, and the peritoneal cavity is opened. The bladder is reflected from the lower segment, and a transverse incision is made on the lower uterine segment, care being taken not to injure the fetus. The fetus. The presenting part is delivered through the lower segment. Traditionally, the lower uterine segment muscle is closed into layers. The uterine cavity should be cleaned not to leave any retained tissue. Then spontaneous delivery of the placenta may reduce blood loss and decrease the chance of postoperative endometriosis. By keeping gentle traction on cord and massage the uterus through abdomen, the placenta and membranes can be delivered. Closure of the uterine wound is followed by peritoneal toilet when any blood or liquor in the abdomen and pelvis is removed using suction or gauze swabs on a sponge holder. The opportunity is taken at this stage to inspect the ovaries and tubes. We can have also a midline vertical incision. It could be in the lower or upper segment of the uterus. Commonly it starts in the lower segment as a small buttonhole incision till the uterine cavity is reached and is extended upwards. This approach is used when the lower segment approach is difficult because of fibroids or anterior placenta previa with large vessels in the lower segment, preterm breech with poorly formed low segment, impacted transverse line with ruptured membranes or transverse line with a congenital anomaly, or transverse lie with ruptured membranes or transverse lie with a congenital anomaly of the uterus. An extreme example is perimortem C-section. In special circumstances, a lower or upper segment, both segments vertical or an inverted incision is made. Immediate postoperative care after surgery is completed, the woman will be monitored in a recovery area to ensure that the uterus remains contracted, there is no excessive vaginal bleeding or bleeding at the incision site, there is no adequate urine output, monitor routine vital signs like blood pressure, temperature, breathing, pain medication is also given. Early complications are hemorrhage, especially if during surgery the uterine artery is ruptured, anesthesia-related complications, infection like prophylactic antibiotic is given. Occasionally there is injury to bowel, bladder, ureters, or the fetus. Late complications are wound infection, secondary hemorrhage are not that uncommon, vesical or ureterovaginal fistula due to visceral injury are extremely rare, and placenta creta. Maternal mortality is extremely low and is usually related to the reason for which a C-section is done or due to anesthetic or hemorrhagic complications and is estimated to be less than 0.33 per 1,000.